Intermittent fasting has surged in popularity not only as a tool for weight loss and metabolic health, but increasingly as a potential adjunct therapy for cancer. Enthusiasts point to studies showing that cycles of fasting may slow tumor growth, enhance chemotherapy effectiveness, and protect healthy cells from treatment-related damage. At first glance, the logic is appealing. Deprive cancer cells of nutrients during fasting windows, and they become more vulnerable to treatment, while healthy cells enter a protective, stress-resistant state. But while the lab-based findings are provocative, the clinical picture is far more complex, and the risks, especially for vulnerable patients, are not easily dismissed. In preclinical models, mostly mice, fasting has shown impressive effects. Studies suggest that short-term fasting can reduce insulin-like growth factor 1, IGF-1, a hormone involved in cell proliferation, which in turn may slow cancer progression. Other research indicates that fasting before chemotherapy might create a differential stress response, where cancer cells remain exposed to damage while normal cells are temporarily shielded by their altered metabolic state. These findings have fueled excitement and media buzz, giving rise to a new wave of fasting protocols marketed to cancer patients. But animal models are controlled systems. Humans are not. What's tolerable in a healthy lab mouse may not translate to someone already weakened by cancer or chemotherapy. Malnutrition is already a widespread and dangerous problem among cancer patients. Weight loss, particularly loss of lean muscle mass, can reduce treatment tolerance, weaken the immune response, increase hospitalizations, and lead to worse survival outcomes. For many patients, especially those with advanced disease or existing cachexia, fasting could tip the balance from resilience to collapse. Even in early-stage disease, the practical risks are significant. Chemotherapy often causes nausea, loss of appetite, altered taste, and gastrointestinal issues. Layering a restrictive eating window on top of these side effects can reduce overall nutrient intake and make recovery from each treatment cycle more difficult. While some patients report improved energy or reduced side effects during fasting, these experiences are highly individual and not a basis for widespread clinical guidance. Another concern is the psychological impact. Cancer already introduces enormous uncertainty, fear, and loss of control. Fasting, with its rigid windows and biological expectations, can become a source of added stress, obsession, or even disordered eating. Some patients may feel they are failing if they cannot maintain a fasting schedule, or may internalize blame if their disease progresses despite following a strict regimen. Others may abandon medically necessary nutrition plans in favor of fasting-based protocols they found online, without guidance from a registered dietitian or oncologist. Clinically, data on intermittent fasting in cancer patients remains sparse and inconclusive. A few small pilot studies have explored fasting before chemotherapy, with mixed outcomes, some suggesting improved tolerance, others showing no significant effect. Larger, well-controlled trials are ongoing, but as of now, there is no consensus or formal recommendation supporting fasting as a standard part of cancer care. The gap between promising theory and real-world safety is wide and potentially dangerous to bridge without caution. There's also the problem of false hope. The wellness industry has a long history of exploiting cancer fear with nutritional claims that sound scientific but lack context. Fasting, with its evolutionary and cellular logic, can seem like a smart and natural choice. But when presented as a near-miraculous intervention, it diverts attention from more grounded, evidence-based strategies: adequate caloric intake, sufficient protein, inflammation control, and support for the gut microbiome. It's important to distinguish between therapeutic fasting under medical supervision and unsupervised, do-it-yourself protocols based on generalized wellness advice. The former may eventually find a place in oncology, in highly individualized cases, with careful monitoring. The latter, however, risks exacerbating malnutrition, undermining treatment, and harming patients whose bodies are already under severe physiological stress. In the end, fasting may well be a double-edged sword. It could offer benefits for some in narrow contexts, but it carries meaningful risks, particularly for those who can least afford to lose strength, weight, or metabolic stability. Until we have stronger evidence and clearer clinical guidelines, the best course is one of caution, supporting cancer patients with nutrition strategies that preserve strength, stabilize metabolism, and work in concert with their treatments, not in opposition to them.